very much for allowing me to be the first guy who actually lectures to the new interns. It's a really big honor, and I want to welcome all of you. In addition, I want you to know this is a safe zone, you're free to contribute without feeling that you're going to be judged. You should make your mistakes here so that you lessen them in the clinical area. That's it. So let's start. This is the EM-CCM conference. It's a little bit messed up, but my name is Hernandez. And I'm a newly minted UI3. I'd like to thank Drs. Chan and Johannes for their help with putting this together. And also Dr. Jarrett and Dr. Kim for helping me out, giving me a lot of advice, and Dr. D'Souza especially for kind of staying on me to do this thing and do it right, and Dr. Wiener for allowing me to borrow a couple slides from his previous lecture. So, this is our case. I'm going to try to go through it a little bit quickly. Patient is a 49-year-old man. This is the way that his family found him. This is the way that EMS found him, and this is how he greeted them. And so the family, the only history that they have, which you can't see down here, but he's got a history of seizures, basically. So let's start off by just having one of the juniors, any intern, go ahead and tell me if you see any vital sign derangements.
Heart rate.
Yeah, what about it?
High.
So it's tachycardic, perfect. And that's about it. So this gentleman received 10 milligrams of midazolam IM, which didn't really touch him. Except to allow a little window of time where EMS did an EKG. I couldn't track down the EKG, but their report says that it was just sinus tachycardia. So this agitated patient remained agitated, and they transported him to King's without an IV. When you first see the patient, or when they first saw the patient, the ABCs were intact, but the patient was tachycardic. And because of his agitation, they could not complete the primary survey. Unfortunately, to eliminate anything on our differential diagnosis, which should remain broad, you're going to have to take care of this problem, agitation, okay? This patient right now is a danger to himself because you can't intervene upon him, and he's a danger to others because he's offering to punch you in the face. So placing that aside, what are some of the things we should suspect drove this patient here? A patient with agitation, altered mental status, and tachycardia. Just shout out some stuff.
Tox.
Good.
Hypoxia.
Good.
Sepsis.
Say again?
Sepsis, trauma.
Sepsis, trauma. Good. Yeah, exactly. So yeah, we pretty much covered it all. Drugs, poisons, sepsis, or other infectious things. So let's move on here. The first intervention on this slide is going to be the most important thing because it's the one that's going to allow you to do anything else. Even completing a primary survey is going to be difficult if you don't take care of that. So this was the option that they chose. Their initial intervention was to kind of smell this guy. So they initially, you can see the dose of ketamine is actually 1 mg per kg, which is kind of a low dose. It's kind of a close to dissociative dose. Some people are going to need more than this. Yeah?
For the ketamine, is that, you said you didn't have an IV, right? So
yeah, so apparently somewhere along the line it was placed. I'm not really sure. That's what the chart said. So I guess he came in, he wasn't that agitated, they placed an IV, and then he lost his marbles again. This was 70 mg per kg, and we're actually going to talk about IM dosing later on, not IV dosing. IV dosing actually gets cleared a lot faster with ketamine. So later on we're going to be talking about IM dosing, but thank you for pointing that out. I did need to mention that. As you can see, the ketamine dose was 1 mg per kg. Some people are going to need more than this. Some people are just going to get dissociated and not really sedated when you give them this dose. And then the rest, you can see, you got a lot of lorazepam. And for the reading I did, it seems like 15 to 20 minutes is a pretty reasonable time span to expect the patient to have been sedated, but this guy just continued going. And in fact, with ketamine and lorazepam, sometimes you can expect sedation to occur well below this 15-minute mark. They finally got him down, and these are the vital signs that they got. So again, one of the interns, go ahead and give me what you think about these vital signs. Let me just see you guys the range.
He's still tachycardic,
Mm-hmm.
and he's
Good. Anything else?
Saturation flow.
Good. So yeah, the things that we have here are tachycardia, tachypnea, hypotension. He is borderline hyperthermic versus fever, and he's also borderline hypoxic. Okay, so it's not clear from the record, by the way, these vitals were probably taken pre-intubation. I spoke to the resident who was involved with the case, and that person felt the same. Because of the saturation, we both think it's probably pre-intubation, but can't be 100% sure. I also want to point out that hypotension is very, very common in the peri-intubation period, so it's a smart idea to have some pressure bags at the ready. And now we have to begin some interventions, right? So these are the big picture things that we have to take care of very quickly. And so I'm just going to give you some spoilers. Basically, even though his temperature was like borderline fever versus hypothermia, didn't really do anything for it. It resolved without any antipyretics. And just for the interns in particular, know that there is a difference between hypothermia and fever. You can look that up later. It's not critical right now. So now let's start off on the ED course. This patient needed a lot of different interventions, but these are the ones that are going to take care of his ABCs initially. He got 2 liters of fluid, giving him circulatory support, and we already talked about intubation. So let's look at the HPI. This history is gathered from the chart and from EMS records. So he was found down by family after an unknown period of time, estimated to be somewhere within the 4 to 5 hour span. And he has had many similar presentations in the past. He's got very poor med compliance. So these are the medications that he is not taking. And he also has a pacemaker. But it was unclear from the chart exactly why. He follows he follows here, so I was unable to access the chart from across the street for skip rhythm or slow heart rate. That was the interpretation. I just assumed that that information would not have been available to the resident in such a chaotic moment. Nothing on social history, nothing on family history. So, do we have any questions about only the history at this point?
Alcohol history?
So that's a good question. No, it doesn't seem like he had any alcohol history.
Did we get the ambulance ACL?
I'm sorry?
The ambulance sheet?
Yeah, so I took some of the information from the ambulance scan sheet. Yeah.
Any recent illness or infection?
No, he had none.
Was the family there? Is this something that's happened before?
Yeah, so this is something that's happened before. Family knows pretty well when it happens to him.
And he lives alone or he lives with people?
He lives with family, so the person who found him left him at like 11 o'clock. They came back home after work and found him in the state.
Yes, compliant with medication.
He's poor, absolutely poor, non-compliant. Yes.
Is there a drug history?
According to the record, no.
How long ago was the stroke?
The stroke, I believe, was 2011.
So this is all presumably post-exo.
He has a family history of seizures, not a personal history of seizures.
No, he's got a
He was like completely fine the day before, or was he sick?
So that we didn't get from the record.
Has this scenario happened before, or is this family?
Plenty of times.
How many pills were left in the bottle?
So apparently he doesn't take them. He follows with neuro, and they said that he's well known to them, and he is super non-compliant with his medications, so he just doesn't take them.
Subtherapeutic better than overdose.
All right, so I
Has the
guess,
drug, do you know, or maybe you looked at a chart, has anyone ever done a drug screen on it?
the drug screen that we did was positive for benzos, which he got 10%. I guess we'll move on because we got a lot to cover. So, your physical examination, this is the general appearance of the patient. The only interesting thing here really is pinpoint pupils, but I read that you can actually get those from even high benzo doses. The rest of his exam is really unremarkable. So regular rate and rhythm, clear lungs, his abdomen was benign, genitals were deferred. His extremities were warm, symmetric tone, all the good stuff that you want to see. And he didn't have a rash, he didn't have anything or bruising in the skin. Neurologically, he didn't have any clonus or hyperspasticity, and he was moving externally extremities times 4 symmetrically. Do you have any questions about this very unremarkable physical exam? Yes, sir.
Once he was intubated on the vent, was he on just a sedative, or he had gotten paralytic also?
So yeah, I didn't mention it. I put it on the chart, but he got, I put it on the slide. He got a rock in order to paralyze him initially. He did not get redosed with it though.
And that neuro exam was the rock went off, or we don't know?
That I don't know.
His combativeness, was it like purposeful movements or was it?
It was, yeah, he was trying to punch EMS according to their sheet that they put in the chart or whatever. That the chart puts in. Yeah.
That's probably difficult to know, but was he tremulous or was he fasciculating or anything like that?
I did not see, well, so the chart actually said he didn't have fasciculations in his tongue, if I remember correctly, but the rest of it is really not mentioned.
Smells like wet wood.
Wet wood, I don't know. That was not technical. So let's talk a little bit about the DDX. Go ahead and shout out some things that you think should be on your differential at this point. We already mentioned one, post-ictal. Anything else? Sepsis. Tox, for sure.
Specifically drugs.
Yeah, so any drugs that you think may actually contribute to this? K2, baby, we see this all the time. Yeah, and then don't forget, not only intoxication, but kind of detox. So withdrawal from benzos, withdrawal from alcohol, and then other things like
Thyroid.
yeah, exactly, thyroid. I'm glad you said it. And don't forget trauma. Actually, one of the interesting ones, CVA here, I saw in a bunch of papers, some patients can actually, especially in this, I think it was like a paper from 1988 or something like that, the right MCA distribution can actually present as agitation with delirium with no focal findings. And this is where this gentleman had his previous stroke. So it's a weird one presenting uncommonly, or it's a common one presenting uncommonly, but there are also a bunch of things here that are common that will present in a common fashion. Okay, so upon reassessment, he was ventilated, obviously, but he does have resolution of his borderline hypoxia, decreased tachycardia. At this point, he's loaded with phosphatidone, and he was placed on a propofol drip. Okay, so some tests that you'd like to see, anything in particular that you feel like you need at this point?
Head CT.
Yeah, I saw people spin the head. Anything else? Once you spin the head, you don't see any signs of intracranial pressure that is elevated. What are you going to do? LP, obviously. Anything else? Yeah, so labs, including the detox, right? So these are the ones that they did. So the CSF studies in particular that they got were cell count, protein, glucose, VDRL, and herpes. I just thought the VDRL was cool because I hadn't thought of it.
And no dimension level?
Yeah, so the dilantin level was non-existent, which is why
Not even because they didn't take it or because of levels.
it was just not. It was less than like 0.08 or something like that. It's the lowest that we can read. This is what they did as far as further testing and consults. They actually got a NICU consult for an admission, and neurology commented that this was a very common presentation for this gentleman, but they still suggested an EEG and topiramate because sudden stopping of topiramate can actually precipitate seizure activity. All right, so these are the results of all the tests. Does anybody want to give me a quick reading on this ECG?
So it's sinus rhythm, it's the P-wave-4, the QRS, it's tachycardic, it's narrow complex, the PR is not prolonged, QT is not, that's about half, and the S, I don't really know what's going on before.
Yeah. Yeah, I mean, I agree with you. It's grossly normal, maybe some pacing spikes right there, right? From his pacemaker, but other than that, really normal. His CT head showed no acute findings. There was an old infarct in the right MCA distribution. Is there anything wrong on this blood gas? Yes, definitely. So this, the high lactate The low pH of the base excess stand out.
Is that, remember, is it a VBG or?
Yes, it's a BBG. Okay. And then on further blood testing, I only highlight the white blood cell count because it gives them another criterion for the search criteria. So we're going to address that in a couple of slides. His LP was actually kind of mildly abnormal. His WBCs were 8, and usually you're supposed to see less than 5. Otherwise, it's unremarkable. Anybody want to read this chest radiograph for me?
I think it was pneumonia.
What's that?
I don't know, the right heart bar was very blurry.
Yeah.
Pneumonia, possible for
Yeah.
triggers.
And you see a pacemaker, so boom, right there, right? It looks like a pacemaker and not an AICD, just because you don't have the big, thick insulation. Radiology read this as bibasilar atelectasis and small left pleural effusion. Really kind of an unremarkable X-ray. But for those who say that, maybe a little bit of a blurry heart border, yeah, at some point it was noted that he had fixed sputum suction through the tube, and a preliminary diagnosis of healthcare-acquired pneumonia was made. I'm going to say HCAP from here on out. So his search criteria were heart rate greater than 90, his WBCs, as you saw, greater than 12. So those two criteria qualify him for SIRS. And for those of you who want to know the QSOFA, he was AMS, and his SBP was less than 100 at one point, which means he qualified for QSOFA as well. So in hindsight, the sputum was probably aspirated, right? Because he sees, he probably aspirated, and he wouldn't have had time to develop a pneumonia, especially if he was afebrile and no history of recent illnesses. But now we're in a nice calm room, we're all freshly showered, and we have a lot of time to reflect and pontificate. But that's not necessarily the environment that we work in, and we all know this. So our consuls gave us the help we asked for. McHugh did accept the admission. They added a cyclovir, and Neuro didn't have any additional recommendations. They felt that cyclovir was reasonable, and they wanted that EEG. His ED course really kind of brief, but pretty eventful. He received some antibiosis for suspicion of HCAP and transferred to the NICU on that same day. Day 1 was status quo. Day 2, he was extubated in the NICU, and his antibiotics were changed to Tezo. Then he was transferred to medicine. EEG was unremarkable. It just had some persistent right-sided abnormalities, and the acyclovir was DC'd. He completed his course of antibiotics in 7 days, and this Tezo was, I guess, kind of geared towards encephalitis. It's not really clear from the chart, but in any case, he was discharged to home to the end. So, the conclusion here, although the patient had a history of presenting in this way, the etiology of his presentation was unclear in the beginning, right? That's why we did the head CT to rule out CDA, and although rare, status epilepticus can present in this way. But, fortunately, the lorazepam, phosphatidone, ketamine, and propofol would all have contributed to the resolution of status epilepticus. And the possibility is that he was post-sickle. But, we still treated infectious causes with antibiotics. So, one more time, I'm going to ask if you have any questions or comments, and if you do not, yes, sir.
I'm sorry if I missed it. The classification of the hospital acquired, was he admitted in the last?
So yeah, as I said, he had this presentation previously, and I guess I didn't make that clear, but yeah, he was in the hospital like maybe a month before, so that qualifies him. It's under 90 days for healthcare acquired. Under 90 days of admission, he'd been admitted for. Yes?
So as far as the ketamine doses, you said they were given
According to the chart, it was IV push.
140 IV push.
That's what the chart said.
So I just want to be clear particularly for the juniors, that's an elephant dose. You give that to an elephant. It's probably in the little pens to tranquilize an elephant. That's a huge amount for an IV push. A 70 is pretty significant amount. And at that point, maybe I would have considered disintubating, because I'm not sure it's just going to work. Some people are resistant to certain sedations, whether it's because they've got their GABA saturated already, and Sage can speak to this. But if, you know, once you get to 140, it's just not good. And you can see it didn't work, they still are going to
Yeah.
have to intubate.
They actually did, and it was because of increasing sedative requirements. You're totally right. That's exactly why the intubation is.
The other not problem, but concern that one should think about is that Ativan takes a while to start, right, to kick in. So other agents that might be a little bit shorter acting, like Bruce said, might be preferable in those situations. And while a while is really relative, in that situation when someone is, you know, really acting very violent, even 5 minutes seems like eternity. And so what happens is that the Ativan ends up building up. You give them Ativan, and someone says, give them more Ativan, and by the time you do get it, if this person wasn't getting intubated, you can have benzostacking. So it's really important to know your sedatives, when to use it, how to use it, the times of onset, how long it's going to last.
Teresa, just, sorry to interrupt you there, but I think 2 milligrams per kg is the adequate dose for ketamine.
Yes, but given the ID that 70 didn't work, and then you're going to add on 140, I don't think ketamine's going to work. I'm not saying not to give it, I'm saying I would switch agents.
For anesthesia and that, you give up to 5
Yeah.
milligrams per kg.
You can do 5 mg per kg, but if it's not working, it's not working. You already gave 70 and it didn't work. I would at that point just intubate it, because it's really about the safety of the patient. And to go at 140, you might as well just intubate that.
Yeah, I think they actually did after the 140 milligram dose. That's when they
It's
intubated.
just not going to work.
That second dose of ketamine, was that for the agitation or to intubate?
I think at that point they'd given enough lorazepam that they decided that at some point, if all of this kicked in all at once, he was going to lose his airways. So I think that's how they intubated. That's what I got from the conversations with the resident. What's that?
So they did a second ketamine and
And decided that that was it, that was the intubation dose.
The other thing too is if you have a patient that has a lot of seizures, you know, and if like I said they have alcohol withdrawal seizures, benzos might not work either. So it's not untypical to not get a response from benzos.
Beautiful. I love this because it's an excellent segue to the topic at hand. Sedation of the agitated patient. I love this. All right, so this is actually part of a suggested pathway to chemical or physical restraints in the emergency department. If you look at the top, that little highlighted question is on both sides, and it leads down a common pathway to either physical or chemical restraints. We like to call chemical restraint rapid tranquilization. So the key question to ask here is the patient a danger to self or others? And more often than not, we use an audio-visual model for defining whether or not the patient is agitated. So let's take this guy. His ABCs are intact because he's cursing the CCT blue. And though he is not in his right mind, he is quite alert, which means that blood is getting to his brain. However, how do we decide whether or not this gentleman is hypoxic or septic, or if he's got thyrotoxicosis? How are you going to figure any of this out when you can't even touch him? You really can't until you take care of agitation. Okay, so agitated delirium is really what we're dealing with this patient that we saw in our previous case. For our purposes, we're going to define it as we saw in the pathway, a patient who's a danger to himself or to others. The pathophysiology for how patients get here is unclear, and there are many theories. And it's so difficult to define, in fact, that even ASAP and others have had difficulty defining it. So I'm going to read you first how ASAP defines it, and that is the difficulty surrounding the clinical identification of excited delirium syndrome is that the spectrum of behaviors and signs overlap with many clinical deceived processes, which is a fancy way of saying we don't know. In another paper by Takeuchi titled Excited Delirium, they describe this phenomenon as delirium with agitation, which they describe as either fear, panic, violence, or hyperactivity, or a combination of all those, and it is accompanied by unexpected physical strength and hyperthermia. So it's like your angel dust patient who's pushing off 5 cops. These are just indications. You should know why you're doing it. You should know if what you're doing has good reasoning behind it, and this comprises a rationale from all the reading that I did that many authors use. So I highlighted the ones that are most pertinent to the emergency department. And remember, don't apply these liberally. This is for the very, very, very agitated patient. Okay? So the appropriate endpoints for sedation are to calm without necessarily inducing sleep, which is not always successful, but definitely you want to accurately assess the patient. Considerations that you should take before taking on this risk of physical and chemical restraints is that you should try less restrictive measures with patients who are actually walkie-talkie, who are able to kind of chat with you. So option one should always be verbal de-escalation. Okay, you should level with them. They're still human beings, even though they're acting nutty. Some of them are going to calm down and chat with them. Number two is verbal de-escalation with bribery, right? So offer them a sandwich, and apple juice, those things can work miracles, a nicotine patch for somebody who's cranky because he can't smoke. Option number three is going to be de-escalation with a little bit of muscle. You're going to chat with them, but the hospital police is going to be standing right behind you. This is done because mentally it allows the patient to say, well, you know, I was outnumbered, but right? So they back down a little bit easier. The next option after verbal de-escalation is to actually offer oral sedation. You'd be surprised. One study I found that 55% of agitated patients were amenable to taking some PO dosage. I know Dr. Silverberg really tries to do that some of the time, get people to take orals. And then I think your penultimate option should be rapid tranquilization or chemical restraint. And it does require a lot of muscle to do safely, as does physical restraint. And let's chat a little bit about physical restraint. So this should be your last stop, and the reason why it is your last stop is twofold. Number one, you are taking away autonomy from the patient, okay? And then number two, there's a high risk of either you or the patient getting hurt, okay? These should be used as briefly as possible, and I like to think of them as a bridge to chemical sedation. This is a mighty big consideration that I want us all to take into account. This is not just a throughput issue. Undressing and gouging the patient is not just about getting them out faster. It's about protecting ourselves. It's a non-confrontational way of checking for weapons, and we know where we work, right? So there is a risk that some patients will have weapons, and this diminishes that risk. Be aware that there is a possibility of sudden death, as I said, and Jacob actually does weigh in on this. But one thing that I want you to know is you should probably document why you're doing it and document it well, okay? So, I just briefly want to go over this. This is not really the point of the presentation. It's more about the chemical sedation. You can look at a video on the EMCrit website, which is actually really good. Teaches you how to do this. But in short, you need 5 to 6 people, just like a recess. One person controls the head, the other kind of manages this thing. One person on the right arm, one person on the left arm, and same for the leg. So one arm up, one arm down, right leg gets tied to the left side of the bed, left leg gets tied to the right side of the bed, we're done. Okay, this is ASAPS. Yes?
So we actually tried this last week,
Mm-hmm.
and it actually did not work very well. The patient still had a lot of mobility, and it didn't work very well. And we did it correct the way people will recommend it, and I'm not sure it's just a great way to do it. Everybody else is free to try it, but we really did not have very good success with it.
Good to know.
One other thing to be aware of.
Yes.
Spinning is common during that process, so be prepared for dodging or having like a mask or a shoe.
I wore masks.
Yeah, triage nurse last night ended up getting paper strips.
Nice. Sounds fun.
Hey, Ron.
Yeah.
So also the other thing, a lot of the time when those patients, when they come to the screening from wherever they come from, the nurses will usually prop them in the bed sort of Hernandez. And that position, like I had a patient, I was with Silverberg, we had a patient that was doing that, and pretty much it's like easy for them to like slip their arms out from that top spot when they're put in that position, which actually defeats the purpose of having this that 30 degrees because it's still slanted down,
Yeah.
so it's still an aspiration risk.
You
So
see
that
how the
up-
bed
up,
is
down,
not really
up, down.
triangular here? I don't know why we do that here. All right, well, good to know. This is real life input. All right, so these are the ASAP guidelines, all right? And there's no, you can see there's no real preference for anything, really. Except when time is an issue here, they say droperidol first over haloperidol. If you have a psych patient, they really don't have any preference over whether you use an atypical or typical antipsychotic. And the thing that is kind of fun to know is that oral dosing of these things is equivalent to IM dosing. So that's why you should chat to some people about maybe taking an oral dose if you can. And so let's reflect for a moment. On the fact that during our literature review, we found that much of what's out there in agitated delirium isn't really in our typical patient population. So that means that things like meta-analyses and consensus guidelines are going to inform a lot of our decisions. There is a paucity of data for what we are often forced to do. So, let's talk drugs. So I actually wanted to put Haldol Holiday, but I was told no name brand drugs. So I do like haloperidol though as sedative in ETOH. It has been used for a long time in sedation in this group, so there's a lot of research, it's familiar, it makes you feel safe. And when akathisia does occur, diphenhydramine will actually help, and we'll talk about it in a little bit. On the con side, there is data out there, specifically from a Cochrane review and a separate Canadian agency for drugs and technologies in health, that found haloperidol to be less effective and more harmful than other antipsychotics. Also, the combination with benzos we like using has like zero good data behind it. Although on the plus side, it did show a trend towards less redosing. And then the thing is, we don't really have a lot of data on whether or not this causes respiratory depression. Let's see. We can kind of look at the akathisia issue indirectly, because there's no data on it directly in patients with agitation. So they did 2 different studies on patients with headaches, migraines. So one gave haloperidol versus metoclopramide, and both groups got 25 of diphenhydramine. And the second study was haloperidol versus placebo with no diphenhydramine. Now these are 2 separate studies, remember. And in both studies, haloperidol was more likely to cause akathisia than its comparator. For example, 43% in the haldol group with diphenhydramine, but when you compare this to the group that didn't get, or the study where people didn't get diphenhydramine, that risk of akathisia was more like 50 to 53%. So there is a pretty big difference. Like 10% may not mean anything for you, but for the patient it may mean something. Okay. Oh, and don't forget, always look out for NMS. Okay. Yes.
There's a couple of other issues potentially, and Teresa's mentioning the QTC. Right?
Oh, the QTC I will talk about.
Patients is potentially an issue, right? Because they're often hypomag and hypoK.
Absolutely.
And in this patient, for this case in particular, how low is the seizure threshold? So it would probably be a poor choice.
Yep. And I'll definitely also address the QTC interval in a couple of slides. Droperidol, I don't really want to go over too much. It's a moot point. We can't access it in the Pyxis. So what's the point of talking about it? But just know that NMS is also a con here, okay? And here's the QT slide that I was talking about. This actually lists QT prolongation from most prolonging to least prolonging. And, QT prolongation, black box that's associated with it is usually why people cite not using droperidol. But as you can see, pretty much everything that is an antipsychotic and a lot of stuff that isn't has QT prolongation. Haloperidol does have the advantage of not prolonging the QT as much as others, but it does have the disadvantage, as we heard from Dr. Muir, of decreasing the seizure threshold, and that's true of many of the antipsychotics. If you want to know more about that black box warning with haloperidol, there's a paper by Horowitz called Droperidol Behind the Black Box Warning, which does go into how it got the warning. All right. And so let's talk about the second generation antipsychotics. There's really not a whole lot of data about them. All right, so they may be less sedating than the atypicals, and less sedating than the benzos, which is good if you want a psych eval on a patient. The American Association of Emergency Psychiatry also thinks that it may be a good idea in ETOH intoxication. But I want you to notice how many mays there are in these sentences, and that's one of the biggest cons. We don't really have a lot of data, especially not in agitated patients in the ED. Usually these are done in psych patients that have been cleared for having no organic disease, just having like psych disease. So that's one of the cons, And also, not being that sedating can be a con, especially in a guy who's offering to punch your lights out. You kind of want that guy more sedated rather than less sedated. You want to err on the side of sleep. And like I said, the biggest issue is really their anticipated. Benzos and haloperidol, they have a lot more history behind them, which makes them feel safer when we use them. Benzos really are a popular agent for a reason. You know, they sedate quickly and well. They're especially helpful in agitation from ETOH withdrawal. They come in many formulations, which gives you options, and they have a fairly rapid onset. The last point up here about ketamine is actually from a literature review comprising 83 studies, 7,000 patients. Ketamine was used just for procedural sedation. This wasn't for agitation. But I thought it was cool that you can actually control emergence reactions to a certain degree, whether you give it right at the beginning, at the end, or PRN. And so, as I said, you know, and actually as was being discussed by Dr. Smith previously, you kind of want to tailor your benzo to the situation. When you want rapid sedation, what you want is midazolam probably. And another reason to use it is because lorazepam and midazolam IM have very predictable absorption. Diazepam is great as a PO dose, benzodiazepine, okay? So benzos do have drawbacks. There's also very little data to understand exactly what happens in ethanol intoxication, which we see all the time. We believe it may contribute to hypoxia in the setting, but the data in that is conflicting. The potential for hypotension does exist, especially in patients who are almost there, who are borderline. And from a throughput standpoint, giving benzos to an already alcohol intoxicated person is probably going to increase their length of stay. The last point here, it says ethanol cross tolerance, since you can't see it, and I tried to find evidence for whether or not there is some relationship with higher dosing of benzos in people who are consumers of alcohol all the time for agitation. I couldn't really find anything except in rats, so we can't really say anything. Dr. Wiener, did you want to add something?
I would just say that in general, benzos is the agent of choice for undifferentiated agitated delirium. Like the person who's agitated, you don't know what's going on, because it's going to be safe in the person who's intoxicated with a sympathomimetic, the person who's withdrawing from a sedative hypnotic, the person who has an underlying psychiatric illness, if they're agitated for a medical reason, it's generally the safest one. There's the maybe increased sedation in the person who's alcohol intoxicated, but I still think overall it's going to be your safest choice. And in terms of choosing which benzo, I think for most situations like this, somebody you're expecting is probably going to need to be admitted. I prefer diazepam if I have IV access, because it lasts a long time and it has active metabolites, but it really has rapid onset if you give it intravenously. Within 5 minutes, you're at deep sedation, so you can rapidly and safely escalate your dose. So if somebody's not as sedated as you want them within 5 minutes, you can give another dose and quickly get to very high doses. Whereas with lorazepam, if you're going to wind up stacking, which is the issue that Dr. Smith brought up before, and with midazolam, if somebody is tolerant and needs a high dose, you may have that first dose starting to wear off by the time you get to a high dose. So midazolam's great when somebody who's a little agitated and you think you might be able to discharge them and you want to be able to do it during your shift. But in somebody you think is going to need to be admitted anyway, I go with diazepam if I can get IV access.
Great, thank you. So let's move forward. So everybody remembers this guy. Now I wonder if he didn't get some benzos at the dentist's office. But yeah, they can have a paradoxical effect, which you can treat with flumazenil, and some would argue in a patient who's already very, very agitated and you don't know what's going on, it's a risk, so you should be aware. This chart does show deaths due to oral benzos plus ETOH in an emergency room setting. 13 states actually contributed their data to this. And this is pretty much a direct evidence that giving parenteral benzos to agitated patients who are ETOH intoxicated may be unwise. It may be risky because there is a risk of death associated with this. So that is also going to go into our cons column. So are benzos necessarily the best solution when sedation is needed urgently? Maybe not for everybody, right? interestingly, in a Cochrane review of benzodiazepines for psychosis-induced aggression or agitation, the authors found only a small difference between benzos and placebo, benzos and second-generation antipsychotics, and benzos combined with haloperidol versus haloperidol alone. They conclude that the evidence doesn't really show any benefit to using benzos when emergent tranquilization is required, but I will put in the caveat that the data that we're using was very low or low quality, even according to their standards. So I don't know if I would always use this in agitated delirium. I think this would probably be more of my go-to. I like to think of ketamine as the shuriken in your arsenal. You use it when you get into trouble, and usually it works out all right. You come out on top. So it should probably be the first thing that you give in a patient who needs to go down now. Like excited delirium, violent agitated patients, brain scene, that patient who set the mattress on fire, that guy needs ketamine. So let's go overwhelming. There are 3 studies that actually show the benefits to using in agitated patients. You can see none of them are really in the ED as an initial dose, but we'll talk about it. So the first study is a pre-hospital study, so EMS did it, and the way they did it, the first 3 months of the year, they used haloperidol 10 milligrams IM. The next 6 months, they used ketamine 5 milligrams per kilogram IM, which is a higher dose than what we usually give. And the last 3 months, they used haloperidol. This was so that seasonal changes wouldn't affect how many patients got the medications. And they used the big dose in order to avoid partial dissociation. They also rationalized, the authors, that the adverse effects with ketamine don't seem to be dose dependent, right? So as soon as the injection occurred, the paramedics started to watch, then they passed off that watch to a research assistant who was in the hospital. They stopped the watch when they reached a certain score. And then what we saw was that 95% of subjects with ketamine were adequately sedated pre-hospital. Only 65% of haloperidol subjects were. And ketamine also required fewer repeat doses. I'd also like to point out the intubation rate here. That's way higher than what we usually see. Maybe it was due to congestants. Maybe people panicked, like emergency room docs panicked when somebody said, hey, look, I gave this guy a 10 ketamine, and they just kind of panicked because they may think of it as an intubation drug. So kind of going through this quickly, this population is truly what we see in the ED, although it was open label science, so there's some evidence that the EMTs weren't giving it. This is ketamine and rescue medication. So it focused on ketamine as a sedative after other sedatives were given. I want to say this was a very, very difficult subpopulation to sedate in a bigger study. And what it comes down to is out of nearly 50 patients, only 5 were not properly sedated after being given 1 dose of ketamine. And repeat dosing occurred at a very low rate with ketamine, okay? The limitations to this are that stacking sedatives makes it impossible to know exactly which sedative did what. So the way that the authors get around this is by saying, look, every other sedative took about 20 minutes to work. These patients were an hour out, and after we gave ketamine, it only took 20 minutes for sedation to ensue. So we're going to assume that the ketamine has something to do with it, but there's no definitive way of knowing. This study is in excited delirium, which is what we're interested in. So what I like about this study is that it shows if you stick it in a cavity, you're going to get some sedation with ketamine. But just know, rectal doses do have a high burst path metabolism, so you may have to increase the doses quicker there. So there were some increases and decreases in BP, but nothing really super surprising. Do remember that laryngospasm is always a very big concern, but it doesn't happen a ton. And it's actually quite rare, as well as intubations, and you can use it in PEDS, which is always a plus. But be aware that, increased agitation can occur. It actually occurs at a rate of about 164 per 1,000. And if there's some underlying psych, ketamine may not be your best ally. You may want to turn to a benzo or even haloperidol. So, moving on. So now that you've got your formally acutely agitated patient, don't forget that the whole point was to be able to examine this guy and evaluate him. Okay, so make sure you do a good evaluation, get the stuff you need. So the ultimate idea here is to ensure that there is no organic cause, some intervention that you can do that will make this patient stop acting crazy. So in other words, make sure that they don't have any metabolic derangements, any trauma, any infections, any treatable cause, right? And so the disposition for our patient, as I mentioned, he was ultimately discharged to home, and 2 weeks later he was back in the hospital for the same thing. So let's go over the summary slide real quick. This is a bit much. You don't want to snow people. Wow! Just did that. So as satisfying as it might be, the point of sedation is not to snow the person who's currently causing you a lot of anxiety. Okay? First, talk. So talk to patients who can talk, offer food, drink, nicotine. If that fails, this sounds like a restaurant. If that fails, offer PO sedation. Okay? And then action. Okay, so in my opinion, I know opinions will differ, but from the research that I did, ketamine 4 milligrams per kilogram, IM should be your go-to in these ridiculously agitated, very dangerous and violent patients. Pragmatically, though, it can only be given in the CCT here. I don't know if somebody wants to do a QI project, might change it, I don't know. But it's great. It works in alcohol intoxication in undifferentiated patients, and most side effects are easily managed. It's got a low rate of serious adverse effects, and you can manage the emergency reactions with benzos. If you suspect psych, though, you should probably turn to haloperidol. Okay, so you do droperidol versus haloperidol. You can give up to 10 milligrams IM. I wouldn't give it to somebody with seizures, but I would add midazolam, because even though the data is not great, midazolam works fast. So the last thing that I want to say is please always put your patients on a monitor if you're giving them any type of sedation. Every year, or not every year, every so often it does occur that we have a patient who doesn't do great because they were not on a monitor when they were sedated. So any patient, kind of, talk to your nurses and make sure that they are aware that this patient should be on a monitor. Any questions, comments? Yes?
So I think that if you're going to use 4 milligrams per kilogram of ketamine, that's a conscious sedation dose. And you're going to get a lot of pushbacks from nurses, appropriately so, because you're doing conscious sedation. And I don't know if that's a great way to go after agitated patients. I also, personally, in my limited experience, do not like to use ketamine for patients who have psych disease, because they're confused with their interaction with the world to start with, and giving them a really strong hallucinogen just totally messes up their mind. And I really don't like to use ketamine with psych patients. It just makes them so confused, and I find even more agitated. I don't like to use it. But I can't give you any literature on it, that's just my personal experience.
Because even IM, you think 4 mg per kg is? 4
mg per kg IM is the conscious sedation dose. 4 mg per kg IV is double the conscious sedation dose. So 4 mg per kg IM is a pretty big dose, and it's not usually like the great idea is to do that in a patient off the monitor, thrash around, that you can't control, you don't know what's going to happen with their airway. Remember, ketamine causes laryngeal spasms in a small percentage of patients. Not the ideal person to be intubating while they're upside down in the bed, trying to jump out. I just don't think it's a great idea. My personal opinion, not literature based.
I appreciate a lot of what Dr. Silverberg's saying. There's a paper out of the Midwest, I can look it up and send it to you if you want, comparing ketamine and benzos. It's also similar to the EMS study. EMS was giving it for agitated patients, IM. They noticed that those patients had increased rate of laryngeal spasm, which is a side effect, and additionally it increased ICU stay. I do agree that it should be in your arsenal. I also agree that it shouldn't be your first line.
Yeah, I think when all else fails, maybe go there. I agree with that, but it's not definitely not my first go-to drug.
And when we use ketamine often for conscious sedation, we talk the patient down, we say think about nice things like that, because there's such a strong emergence reaction as well. If the patient's already agitated and they wake up even more agitated, it's probably not safe for them or the environment.
Yeah, I think we have one more comment and then I have to relinquish.
I had a question. Is laryngeal spasm dose dependent? Like the more you give, the more likely?
So and you actually get laryngeal spasm and you get transient apnea also.
Yeah,
have to
you
push it faster,
definitely do
so-
get transient apnea.
And
That's shortly after the injection, you may see that. Yes.
Just one pitch, if you want to discuss that first ketamine versus haloperidol paper more, we're going to be discussing it at Food and Journal Club.
Also, please note that this is, somebody's going to adapt this for the blog, so stay active on the blog. It's a fun time. All right, guys.
One really quick thing.
Yeah.
So you're just talking about how diazepam IV is great. It's not great IM.
Yeah, no, it's not. You don't want to stick a pill in somebody's thigh.
It has very erratic absorption.
Yeah, exactly. All right, guys. Thank you so much.